Uganda Medical and Dental Practitioners Council is a government agency which regulates medical and dental practice in this country. And it was first established in 1933, so it has been really around for a long time, but has been undergoing several amendments. And the act that currently establishes the council is the Medical and Dental Practitioners Act, Cap 300 of 1998. But this act is currently under review at the moment to make the Health Professionals Authority. You may have had issues about merger of government agencies. Yeah, so the councils were exempted from that merger, but it was decided that an authority be formed to oversee the councils. So that process is still ongoing. So we also have other regulatory bodies in the country. We have the Allied Health Professionals Council, which regulates the allied health professionals, including the Bachelor in Anaesthesia graduates, which I'm sure are in the room. So those ones follow under the Allied Council. We also have the Uganda Nurses and Midwives Council, which regulates the nurses and midwives. And we have the Pharmacy Board, which regulates the pharmacists, who are now also called doctors, who acquired the title by proxy, by gazetting it. So what is the mandate of the council as far as regulation is concerned? So according to the Act, the council has 4 main roles. Number 1 is to monitor and supervise medical and dental educational standards in the training institutions, including continuing education. And I'm going to expound on each of these laws in the subsequent slides. So our role starts with the regulation of training from the medical and dental schools, M.Med training, fellowship training, any type of training or education is regulated by the council. And then after that, we register all the eligible medical and dental practitioners in the country. So those who qualify after training, we are required to register them. Then we enforce acceptable standards of medical and dental practice, and we investigate reported cases of malpractice and take appropriate disciplinary action. So these are the 4 main roles of the council. And if I'm to expound on them, under supervision of medical and dental educational standards in the training institutions, we currently have 14 medical schools in the country as listed, and they are balanced. 7 of them are public, 7 of them are private. These are the ones offering MBCHB training. So Makerere, Mbalala, Gulu, KIU, Busitema, IU, KCU, Soroti, Lila, Equator, UCU, Kavale, and FINS. Of these, the ones which are offering M.Med training in Anaesthesia, we have Makerere, Mbalala, and KIU. Not so? So if you are training in another university, M.Med, we don't know it. Then we also have the upcoming medical schools. These are new. They have written a curriculum and they are about to be accredited by the National Council. We have what we call a JEF International University. I don't know if you have heard about it. It's in Butavika. We have Avansi International University. It's on Masaka Road, and then in Deje University. So these ones want to start MBCHB programs. And so if you want to teach, the opportunities are there. For the dental schools, we still have few. Only Makerere, UCU, Dental, KIU, and Equator are offering dental, bachelors in dental surgery. But there's also an upcoming dental school in Jeff International University. So what this means that actually we are now producing more doctors every year. This year alone, we got about 1,118 who registered to do internship. But some of these schools haven't graduated. So as every year passes, we shall be getting more and more graduates. And then on top of this, we get graduates who train from outside Uganda, the East African community, and overseas. So what do we do currently? We supervise, we do joint inspection of these schools together with the East African Community Medical Councils and the National Council for Higher Education. So this is a shared mandate with National Council for Higher Education, but we work together. We collaborate in this. So the schools are accredited by National Council. So don't say that Medical Council is accrediting many schools, okay? And for it, so long as the school meets the minimum standards to run a training program, National Council accredits it and tells it you can go ahead and train. So meaning that there is no limit on how many medical schools we can have. And then we also review curricula for all medical and dental programs. So all the curricula for these programs are reviewed by the Medical Council because we have that technical expertise. And I'm glad that some of the experts here have reviewed some of these curricula. We also accredit fellowships and subspecialty training. This is a sole mandate of the Medical Council that subspecialty trainings are accredited by the Council, and we have some good examples under Anaesthesia, which I'll talk about later. And we do indexing of medical and dental students to know. So as I've told you, we have the numbers of medical and dental students that will be graduating every year because we know how many are in third year, how many are in second year, and these numbers are likely to increase. But the question is maybe that are these numbers able to offer safe anesthesia? So the second law is to register all eligible medical and dental practitioners in Uganda. Eligible meaning that they have qualified and they have done internship. So registration starts with provisional registration. Provisional registration is given to those who have completed medical school and they are going to undertake internship. Then when they finish internship, they get full registration. But the foreign doctors get temporary registration. And I believe all the doctors in this room are registered. Not so? So the foreign trained students do theory and clinical exams with the council, what we call MLEB, the Medical Licensure Examination Board. So those who train from outside East Africa, when they come back, they first do theory and clinical exams before they can be, and if they pass, they go for internship. And there are also plans for joint fifth year, a joint pre-internship exam for all, even those who are locally trained. We have benchmarked this within our member states like Tanzania. They are doing these exams. So we want to do the same because now with the increasing number of graduates, how can we be sure about their competence? So the council is proposing that we give an exam to all of them. But there are many opposing forces to this, including some among the room. But we shall go ahead. What we are still working on is a law to enable us to do this. And under registration to date, as of yesterday, there are 10,175 registered practitioners in Uganda. All of us, we are about 10,175. That is from 1998 when the council was formally established. But out of those, the anesthesiologists were only 106. So you can see the gap. I don't know that is worth celebrating. I don't know whether it's really celebrating. You are one of the orphan specialists. There are very few specialists. And I think this one of my call to action is to see how to increase this number really. Arthur showed us that the ministry wants how many anesthesiologists? Government alone, 29. But the demand is even higher. And out of this 106, I don't know how many are members of the association. You may find that not all of them are. Or you may be having more members than we have on the register. So we need to compare and see. Okay? Yeah, so if you want to know who these 106 are, you can write to us officially. We shall tell you. So, and then to enforce acceptable standards of medical and dental practice, to do this, we issue annual practicing licenses. And of the registered practitioners, the 10,000, this year we have got 7,336, which is 72% renewing their license for 2025. meaning that the other 28% have not done so. And we have actually done a study to understand why some doctors don't renew their license. Yeah, so one of the reasons we found that the older doctors usually don't, and also the doctors who are more specialized, they don't renew their license. And we are trying to understand why. They are defiant. Yeah, but we also noticed that depending on your employer, that those who work in private practice tend to be compliant compared to those who work in what? In government. But surprisingly, even among anesthesiologists, 78% are licensed for this year, 81. 81 out of what? 105. So what's the balance? About 25 of you have no license. So I actually wondered, because anesthesia is one of the risky professions. This is the profession you can't risk practicing without a what? A license. So I don't know who among you can dare not have a license. But actually, it is very easy to know who doesn't have a license. Let me just show you something here. I'm going to show you the one who has, not the one who doesn't have. So if you want to find out who has a license and who doesn't, you come to this portal of Health Professionals Portal Uganda, the www.ehealthlicense.go.ug. And you want to find a practitioner, you just come here. You don't need to log in. You just put there UMDPC, and you put a name. Whose name should I put? Let me put Erasmus, because it's the most talkative. So if you put Erasmus, so it will show you that in the register we have 3 Erasmuses, if that's the right English. So you'll find Erasmus, a rebel, then it will also tell you his qualifications and also tell you his registration number. So Erasmus is active at least. And also what we have noted, most of you have not registered your additional qualifications. So you are there saying, I'm a critical care specialist. But according to the register, you only have M.Med anesthesia. So you are masquerading as a critical care specialist. You are only recognized for a specialty or subspecialty if you have registered it with the what? With the council. Are we together? Yeah, so that's the message here, is that, so with this online portal, you can easily search. If you find someone in the field and say, I'm an anesthesiologist, you just come and search. And by the way, if you are still doing M.Med, you are not an anesthesiologist. You only become a specialist upon registration with the what? With the council. We know many of you move around hospitals in town that I'm an anesthesiologist. That's not right. That is just for caution. And you know that we have entered the period of renewing licenses. So please make sure that you comply. Okay? The other thing I wanted to show you on this portal, we also have what we call CPD providers. So if you want to know who the CPD providers are, I tried to search for the association, and I actually found that the association is an accredited CPD provider. It was accredited in 2022, but I hope that it is giving you CPD points. Like this conference, you are going to get how many points? You have been here for 3 days, not so? 8 points per day, because if the conference is from 9 to 5, those are 8 hours. Time with 3 days, those are how many? 24 points. So already from this conference, if you have attended all the 3 days, you are getting 24 out of the required 48, which is a 50%. Isn't it? Yeah, so, and we require you to have those points before you renew your what? Your license. So just make sure that if you have attended the full day, you get those CPD points. Are we together? Okay. So the other call to action I really make is that as an anesthesiologist, you can't risk working without a what? I know some people call it that paper, that simple paper. It is simple, but it is a legal what? Document. However skilled you may be, if you are reported to have been involved in a case and you didn't have a license, that is the end of the story. So the council also issues operating licenses for health units, and we conduct inspection of the health units. We coordinate CPD activities. So this coordination of CPD activities, we have delegated it to the associations. Like I've showed you, the Association of Anaesthesiologists of Uganda is an accredited CPD provider. Yeah, so, and we recognize the sessions that they hold, okay? And then we educate the professionals and the public, like I'm doing now, to sensitize you on these matters. The sensitization of the public, we have not been very active in that area, but we have embarked on that through media. So the other role we do is to investigate reported cases of malpractice and take appropriate disciplinary action. And the disciplinary cases we usually handle is professional misconduct, medical negligence, and medical incompetence. And these cases, it is determined after the case has been reported to the council, we conduct a thorough inquiry, and then the council comes up with a ruling. You may have seen some of the rulings from the council. And professional misconduct simply means a profession violating the professional code of ethics, which I hope we all know. It is available on the UMDPC website. You can look at it. How are we expected to behave as medical professionals? How are we expected to treat patients? How are we expected to dress? How are we expected to behave in society? Then medical negligence usually looks at the aspects of, it has 3 ingredients. One is that a practitioner owes or has a duty of care for the patient. Then there is a breach of the duty of care, and then patient suffers harm as a result of that breach. Okay? So those 3 ingredients, when we are testing whether there is a case to answer or not, we look at it. Did you have a duty of care for the patient? Yes. Did you breach that duty of care? And did the patient suffer harm as a what? As a result. So if we find that, then you are what? Negligent. And most of the cases of negligence we are getting, they are mostly around, they are mainly in obstetrics, anesthesia, and surgery. That's why I said you're one of the most risky professionals. It is very common to have cases of purported what? Negligence in these 3 fields, okay? And we have had quite a number of cases, and usually what is happening around the anesthesia area is issues to do with overdosing the patient, spinal anesthesia going high. I don't know whether that is an accident or it is expected. Depending on the provider. But also, if it happens, what do you do? Okay? How do you handle it is the question. But what we have noted, with due respect, is that most of these cases happen in the hands of the anesthetic officers. And when that happens, the vicarious liability is put on the surgeon. I don't know if you get what I'm saying. So there's what we call vicarious what? Liability. Who has the responsibility on the patient? If a surgeon is working with an anesthetic officer, the vicarious liability is on the what? Surgeon. But if a surgeon is working with an anesthesiologist, the vicarious liability is on the anesthesiologist. I hope you get what I'm saying. You may have seen one of the cases where the council ruled, the surgeon worked on the patient, he did hernia, how do you call it, undescended testes. That one, okay, the plexi. So they worked, they were in theater about 2 hours, then patient goes into recovery room. Then during recovery, the patient wails in pain. Then the anesthetic officer comes and gives 100 milligrams of pethidine. Then the patient gets a cardiac arrest. So the council found the surgeon liable for that. But if it was the anesthesiologist who had given it, you would be what? Answerable. Okay? So those are some of the cases we are getting. So issues of incompetence. How do we determine medical incompetence? This comes in when a person does something beyond their level of training. Like you do a procedure or you offer a service which is beyond your scope of what? Training. But then I know someone is going to ask, so what is the scope of practice? Okay? For the anesthetic officer, for the diploma holder, for the degree holder, and then the anesthesiologist. Then even among anesthesiologists, you have cardiac, pediatric, and so on. So I think that's also another area where the association should assist us to know who should do what. Okay? Then we have issues of fitness to practice. Is a practitioner fit to practice? And this looks at their ability, their physical and mental state. So we have issues of age. Currently, we have no age limit on practice. So someone can practice as long as they are alive. But they can be assessed to see if they are still physically fit to do what? To practice. Especially you people who stand for 8 hours in theater. 12, okay, 24. Issues of alcohol and drug abuse. We are getting many cases at the council of practitioners who are misusing alcohol and your drugs mostly. Pethidine. Actually, you are the major culprits for this. So doctors are misusing what? Pethidine. Which other drug is very good? The one which takes you up there. You call it euphoria. Fentanyl. So if you are dependent on those drugs, then you are not fit to do what? To practice. And the call to action here is please inform the council of our colleagues who have this problem so that we can help them. So that we can help them but also protect the what? The patient. Because if you don't inform us, actually you become an accomplice. So if we find that you have been working with him for 2 years and you know his problems but you didn't what? You didn't report, you become a what? An accomplice. So you tell us in confidence, we call it whistleblowing. Okay? Then we have issues of physical or mental illness. This is natural. Any one of us can get a physical what? Illness. If, God forbid, you got an accident and your arm is lost, can you still offer safe anesthesia? With one arm? You must be a genius to do that. How will you? I remember when I was doing, by the way, the other interest I got from emergency care is when I went for an observership in emergency care in Korea. The best I came to was to intubate a mannequin. So to intubate a mannequin, you have to shoot here, and then you do what? You push in that thing. So I don't see how you can do that when you have one arm. Skill-based. Yeah, so if really someone has a physical condition that can prevent them from properly exercising their skill, then the council has a duty to protect, to stop them from working so as to protect the what? The patient. Because you know, you people, you think you have to act very fast. You call it rapid sequence induction. You see, I still have a lot of knowledge, by the way. So how do we ensure safe anesthesia practice? It all comes from what I've said, okay? But just to wrap it up, so one, we have said that we register and license anesthesiologists. And I've told you for now, for us, we only know 100 anesthesiologists. Ugandans at least. Of course, we have some foreigners. And then the licensed ones. Okay? Those are the ones who are authorized to work. Then we monitor and supervise their training and practice. So I've told you we supervise undergraduate, postgraduate fellowship training. Then we accredit fellowship programs and fellowship training sites. So this one is a sole mandate of the Medical Council. Fellowships, which are by apprenticeship, they are only accredited by the what? The Medical Council, not the National Council for Higher Education. And actually in line with this, you may have heard that we are in the process of accrediting the Canexa Fellowship. We are still in the process, not yet complete. So if you are doing it now, we don't know it. The other day, someone came to my office with a Canexa certificate. So I asked him, how did you get it? He said, but I was in Imbalala, but I also got it. I said, no. What we know now is the M-Med, which we have done in Imbalala, but we don't know the Canexa yet. Okay? So the other fellowship program we have looked at is cardiac anesthesia and critical care of Uganda Heart Institute. That one I'm happy to report that 2 days ago the council accredited it. So that fellowship in cardiac anesthesia and critical care of the Uganda Heart Institute is accredited by the what? By the council. So if you are offering it, you are doing a legitimate course. Are we together? We are also still looking at the other fellowship programs at Heart Institute. We have quite a number of fellowship programs at the Cancer Institute. We have accredited a fellowship program in Urogyne at MAST. We have also accredited, we are in the process of accrediting the critical care fellowship under Mulago. We received the curriculum and it's still undergoing review. We are also still in the process of accrediting the PATA fellowship, but the process is still going on. It's not yet complete. Then we issue guidelines for safe practice. We have issued a number of guidelines. Currently, we are working on the guidelines for classification and operation of private health facilities in Uganda. And this is where we shall need the input of the association. One of the challenges we find when we are inspecting facilities is the setup of the theater. You know, you go to a facility and they have a very small room like this with a bed there, with some light of a bulb, not this one, but these usual bulbs you have in your bedroom. And they call it a theater. And they are doing major operations, cesarean section. There's no general anesthesia machine. They are using spinal. And who is doing the procedure? A newly graduated medical officer. Who is giving anesthesia? There's someone who told me he's using an anesthesia assistant. So I asked him, who is that one? This one was trained on job. So there are anesthesia which is trained on job. You may have heard the case of Semanda. When we went to his facility, we found that for him, he was doing the cesarean. Then his wife is a midwife. He was the one giving anesthesia. So it seems it is very easy to give anesthesia, by the way. I don't know why it takes so long. You find people, and they tell you, so who gave the anesthesia? You see their name. And so what did you use? We gave pethidine. Ketamine. And the patient went to what? To sleep. Then we go up country and we find medical officers who are working with no single, even anesthetist. So the medical officer gives the anesthesia and then does the what? The operation. But we tell them, my dear, this, even if you're in a government setting, if things go wrong, no one will do what? Will protect you for this. So we are working on those guidelines. So we want to define what should a standard theater look like. Those machines you are seeing at the back I don't know whether because they are very expensive, people don't have them. Maybe you people who sell them, please bring down the prices. But for real, most of these cases you are hearing of mothers dying in clinics. When you go to the clinic, the anesthesia is very bad. You do the little obstetrics I did, even if you give a spine anesthesia, you told us that you should have a provision for general what? Anesthesia, unless that teaching has changed. So you wonder how someone can have the audacity to do spinal without a provision for what? For general. Someone starts a major operation when they don't have blood. Then the mother gets PPH and does what? And dies. So this is really the reality out there, but we want to work with the professional associations to help us. We are working on the scope of practice for the different cadres. This is still work in progress, and that's where another area we want the associations to help us to define who should do what. What should the medical officer do? You know, there are medical officers who are doing prostatectomies, they are doing craniotomies, and even you, the anesthesiologist, you give the anesthesia for the medical officer to do such a big operation. So we investigate reported cases of unsafe practice and take appropriate disciplinary action. We have quite a number of cases, but in interest of time, I will not share all of them. But if you are interested, those rulings are on the UMDPC website. And as I've said, most of them involve anesthesia. They are mainly operative cases. So you see the beauty with us in internal medicine. When our patients die, they think the problem is, it is a natural what? A natural death. So we are somehow safe. So much as we get little money, but we are safer. So when you are choosing a discipline, please, but now for you already converted. In some countries like Kenya, actually professionals like you are required to have professional indemnity before you can be given a what? A license. I think this is something we should introduce in Uganda. Because the costs awarded to these cases, even you, anesthesiologist, may not manage to cover it. You saw a case in Kenya where the court awarded 4 billion against that doctor who was initially in Uganda. He was registered in Uganda, then he went to what? To Kenya. So we then also request you to participate in sensitizing practitioners and the public on safe and ethical practice. So these are just some of the pictorials where we have worked direct on issues of anesthesia practice. This is one of the, and I guess some of you are in this photo, we are at the Mulago Specialized Women and Neonatal Hospital to inspect it as one of the Connexa sites. We actually inspected 6 hospitals, Mulago Main, Heart Institute, Specialized Women Cancer Institute, Imbarara, and Imbali. Okay, and the reports are available. Yeah, so that was one of them. Then here we are inspecting recently the Heart Institute for the fellowship training in cardiac anesthesia and critical care. We had to involve an expert. You can see him here. He's called Dr. Edwin Lugazia. I'm sure many of you know him. So we had to co-opt him from Tanzania. Because the only cardiac anesthesiologists we know in Uganda, we are the authors themselves. That is Cornelius, Sempira. So we couldn't ask them again to vet the same what? Program. That's why you have to go to outsiders. And it really gave us very good input. The fellowship in critical care medicine, the reviewer is in Kenya. And that's why it takes a bit of time to have them approved. Because we really have to look for a content expert who is neutral and objective, so that we can have really quality assurance that the program is well written and is well offered. Yeah, so this is the fellowship that we have recently inspected, and it got approved yesterday, but one. Here we had gone to theater. We also go to theater, by the way. We don't stop in the office. So I can see the Heart Institute team, Dr. Is it Doreen? The pronunciation. Let's say Doreen. Yeah, so she played a very big role in having this program accredited. I think she deserves an applause. Together with Cornelius, because I remember everything the expert asked, they say, yeah, we have that one. The only thing they didn't have is ECMO. I remember that abbreviation, but I've forgotten it in full. Okay, so yeah, so Heart Institute has been found appropriate to train fellows in cardiac anesthesia and critical care. And what we are aiming at as a council, we want to build local capacity so that these fellowships are offered locally. So that you people don't have to go to America, Europe. You go there for 1 year and you only observe. Then you come back saying, I've done a fellowship. Or even do it online. Colleagues, we don't recognize online clinical fellowships. That one I have to make it clear. It is good for you to acquire that knowledge, but how are you going to acquire the skill? Can you learn how to give epidural anesthesia online? I don't think so, really, as a physician, because I don't see how you are going to fill the intercostal space and then put in the needle. Is it intercostal or? Hey, but there is an intercostal space. Okay, that one. Whichever space you are feeling for. Okay? So we have issued guidelines on what fellowships can be recognized by the council and what can't be recognized. And we have said that for a fellowship that is post-M-Med, it should have been done for at least 9 months. That's the minimum. And should be hands-on, meaning that even if you went to Canada, you need to show us a license that allowed you to practice in what? In Canada. And you need to show us a logbook of the procedures you did when you were rotating there. So if you only observed, thank you for observing, but please, we are sorry. That one you only observed, but you didn't do. But we know that if the training is locally offered here you have an opportunity to do things hands-on. Then you can go there to just see what is in advanced countries, just to add on your knowledge. But not to say that I've observed, therefore I'm a fellow in pain medicine. So this is still UHI. We are really impressed by the capacity at UHI, both human resource and infrastructure. And if you haven't been there, please, you can go and benchmark. So lastly, this is the call to action to the Association of Anesthesiologists of Uganda and Intensive Care Society. Because the council doesn't work in isolation. The council works with the professional associations and the practitioners. And the council cannot be everywhere. That's why we rely on you to give us information. If you have queries about a colleague who you think the thing they are doing is not right, you inform us. Don't hide them. Don't just look on, because that compromises safety of the what? Of the patient. So the first call to action is to expedite the requirements for accreditation of the CANEXA and PATA fellowships. I'm sure the executive knows what requirements I'm talking about. So let's have this worked on so that we are able to have these fellowships accredited, so that we are able to increase the number of anesthesiologists in the country. The second one is to ensure all qualified anesthesiologists are registered and licensed by the council. The key word here is qualification. Qualified meaning, so for you to come and register, you must have your university, a certified copy of the university transcript and certificate. So please don't come with a testimonial. So if you still haven't done your research, then you have not yet what? Qualified. So you shouldn't hold out as a specialist. Holding out means someone who is practicing in a specialty which they don't what? Belong to. And I've said the only way we gauge you is by virtue of your license. If your license doesn't have M-Med Anaesthesia, then you are not a what? Then we need continuous CPD sessions and award CPD points to the participants. I think AAU has been doing very well in this area, and we acknowledge that. We know about the partnership you have with the SCALE program that Professor Arthur talked about. And I think you hold, is it monthly or weekly sessions? Okay, you used to have those sessions. Please keep them continuing, and let us encourage as many doctors, even medical officers, to attend so that at least they acquire the knowledge. And then award CPD points. Some of the complaints we are getting is that some of the accredited CPD providers are not awarding the points to the people who attend. And you know what motivates people to attend is to get the what? The points. Even before they get the knowledge, they want to get the what? The points. So, and then share information with the council on issues concerning training and practice. Me, I'm a bit, should I say Gen Z? You can send me a WhatsApp, that is okay. We can take it from there. But the formal way is you write an official complaint that to the registrar. I'm reporting Dr. who? Cornelius. He worked on a patient and the patient got a cardiac arrest and he died. Please interest yourself in this matter. Then we shall now take it from there. But also when we start inquiring, then we have to call you and you give us more information. No, yeah. By the way, there's some information we got that when the SHO is in transit between being an SHO and becoming a specialist, where do they belong? Are they specialists? Are they MOs? They are medical officers, special grade. No, there's no specialist in transit. So you are still a medical officer. And if things go wrong, you'll be looked at as a what? A medical officer. So ideally, you are supposed to work under someone. Are we together? I emphasize that because we got whistleblowing about that practice in the anesthesia area. It is very common. And then we ask you to participate in council activities whenever called upon. Things like reviewing curriculum, and I want to acknowledge many of you have done this, giving us expert opinion, giving us guidelines. It is pro bono work, but please turn up. Don't refuse to do the pro bono work. I thank you. Thank you very much.